a cannabis would typically ask, how many times in the past year have you used an illegal drug or used prescription medication for non-medical reasons? If the answer is yes, I would begin to further assess by inquiring about quantity and frequency to determine risk, and then further inquire about how much, how often, and document weekly average. The next step would be to incorporate the 3C's checklist for cannabis use disorder: cravings, loss of control. This would include using larger quantities over a longer period of time, unsuccessful attempts to cut back, increased time spent buying substances, using substances, or recovering from the effects of the substances. The third C is consequences, which would be failure to fulfill major obligations, social or interpersonal problems related to use, activities given up due to substance use in hazardous situations, and medical and psychological consequences. Examples of the impact on patients' life could include a person not being able to show up for important parts of their life. For example, missing work or a parent-teacher conference for a child because of the hangovers. Physical problems would include an abscess from injection or mental health problems like a new paranoid delusions. Substance use that has an impact on a person's life is termed problematic or chaotic use. Many patients don't identify with having a substance use disorder or the diagnostic term of a substance use disorder. Instead, patients often connect that there's a problem with their use or chaos in their life because of the substance use. Next would be the evaluation, which includes risk of current use, including overdose and withdrawal, initiation. How old were you when you started using cannabis? Patterns of use, how much, how often, route of administration, treatment attempts in the past, and their outcomes. Details regarding prior treatment for substance use disorder and how they did with the treatment. What were the goals? Were they met, and for how long? The effects of the substances, knowing if there's a medical or psychological effect or negative effects on life. I also like to know if there's ever been a period of abstinence and kind of what has worked in the past and what their previous prevention plans have been. Sometimes with interviews, it's hard for people to answer those questions. So you may consider some commonly used self-report screenings for cannabis use disorder. The first is the cannabis abuse screening test. The cannabis abuse screening test looks at lifetime use and is targeted for adolescents and young adults. It is a 5-item scale designed to identify patterns of cannabis use leading to negative consequences. Questions include, have you ever smoked cannabis before midday? Have you ever smoked cannabis when you are alone? A score of 6 or above using full-scale scoring is considered a positive screen for 6 cannabis use problems. The next one is the Cannabis Use Disorder Identification Test. The Cannabis Use Disorder Identification Test revised is an 8-item scale that aligns with the Cannabis Use Disorder criteria in the DSM. Example questions include, how often do you use cannabis, or how many hours were you stoned on a typical day when you had been using cannabis? A score of 8 or above is considered positive for hazardous use. A score of 12 or above is considered positive for possible cannabis use disorder. The third one is a severity of dependence scale. The severity dependent scale is a 5-item scale that looks to use over the past year. This scale is designed to determine the client's feelings of impairment and preoccupation with drug use. Example questions include, Did you think your use of cannabis was out of control? Or did you worry about your use of cannabis? A score of 2 or above is considered a positive screen for cannabis use disorder. The final one is problematic use of marijuana. This is a scale that looks at lifetime and current behaviors targeted for adolescents. The scale is an 8-item scale. Questions include, have you ever skipped school classes or came late to school because of a cannabis use? Or do you often feel the desire for cannabis? A score of 2 or above is considered a positive screen for cannabis use disorder. Assessing individuals' coping strategies and self-efficacy can support their maintenance of behavior changes when it comes to using cannabis. Screening and assessment can greatly facilitate recognition, evaluation, management, and treatment of individuals with cannabis use disorders, and a number of evidence-based cannabis-specific measures. Abuse-related problems are important in evaluating the impact of cannabis use on a user's life in the effect of treatment. Here is a list of screenings. Measuring cravings and withdrawal can provide some indication of the severity of cannabis dependence. Using screenings to find out why someone uses or wants to quit using cannabis can be informative in the treatment context. There are additional screenings for expectancies, which generally refer to the expected effects of using cannabis, but some measures of expectancies also tap into the reasons for use and attitudes towards use. Assessing individuals' coping strategies and self-efficacy can support their maintenance of behavior change when it comes to using cannabis. Screening and assessment can greatly facilitate recognition, evaluation, management, and treatment of individuals with cannabis use disorder, and a number of evidence-based cannabis-specific instruments are available to aid healthcare providers and other clinicians achieve positive treatment outcomes with their cannabis use patients and clients. So let's go on to medications approved for cannabis use disorder. There are currently no FDA-approved pharmacological treatments for cannabis use disorder. However, in clinical studies, some medications show promise for treating cannabis use disorder. The decision to incorporate pharmacological treatment should be done with the understanding that efficacy and, in some cases, safety and tolerability are still unclear. Regardless of modality, close follow-up early in the treatment course is often beneficial with the patient's permission. Interval drug testing and the involvement of collateral contacts can be helpful for assessing progress. Also to note, if a patient is open to me and if I ask about use and they share, typically I do not do a urine drug screen at that time. I would like to go over some of the research articles that I reviewed discussing the efficacy of medications. The first one I would like to talk about is pharmacotherapies for cannabis use disorder, a systemic review and network meta-analysis. This was done by Baja and his team in 2021. They completed a network meta-analysis aimed to determine the efficacy and acceptability of pharmacotherapies for cannabis use disorder. The 24 trials were diverse regarding study design, outcomes, population characteristics, and interventions. The median trial duration was 12 weeks. 3 studies involved post-intervention follow-up ranging from 4 to 13 weeks. Most trials occurred in outpatient settings. However, 3 involved inpatients and 1 was mixed. Across the studies, there were 1,912 individuals. 986 received active pharmacotherapy, while the rest received placebo. The majority were male. The mean age was 30.2 years. The participants primarily received a diagnosis of cannabis dependence. The majority of the studies excluded participants for psychiatric or medical comorbidities. 8 studies included individuals with the co-occurring conditions, including major depressive disorder, alcohol use disorder, and a mixture of different anxiety and mood disorders. All the studies involved a placebo comparator. The primary outcome determined only nabilone, topiramate, and FAAH inhibitors were associated with a significant reduction in cannabis use. Overall, this outcome was highly heterogeneous. Dronabinol appeared to improve retention and treatment relative to process. While Topamax worsened retention and treatment, they also observed low heterogeneity and retention in treatment. The secondary outcomes included discussion of adverse events, abstinence, cannabis withdrawal, cannabis use disorder severity, and cannabis cravings. With looking specifically at adverse events, while buspirone, venlafaxine extended release, and topiramate were associated with significantly more adverse events, only topiramate was associated with significantly more dropouts due to adverse events. Overall, this outcome just demonstrated low heterogeneity. Abstinence. Most trials reporting abstinence included subjective and objective measures of cannabis cessations. Venlafaxine extended release was associated with worse abstinence. However, no pharmacotherapy is improved abstinence. Heterogeneity and inconsistency measures were low. With cannabis withdrawal, instruments for measuring cannabis withdrawal included Needs Irritability Scale, the Cannabis Withdrawal Scale, and the Marijuana Withdrawal Checklist. None of the investigated pharmacotherapies were significantly better than placebo at reducing the severity of cannabis withdrawal. Overall, this outcome demonstrated high heterogeneity. Cannabis use disorder severity was variably defined using different measures. None of the medication reduced the severity of cannabis use disorder. Heterogeneity and inconsistency measures were moderate. The severity of cannabis cravings was most frequently measured with the Marijuana Cravings Questionnaire. The only pharmacotherapy to significantly reduce cannabis cravings was gabapentin, while vilazodone significantly worsened cravings for cannabis. Overall, this outcome demonstrated moderate heterogeneity and low inconsistency. It was noted that several previous reviews were examined for cannabis use disorder treatment. There appeared to be multiple neurotransmitter systems involved in the neurobiology of cannabis use disorder. It's not really surprising that there may be potential roles for various pharmacological therapies targeting multiple receptors, agonism, antagonism pathways. For example, CB1 and CB2 cannabinoid receptor modulators like nabilone and dronabinol may mitigate the extent of cannabis withdrawal. In contrast, antidepressants like fluoxetine, venlafaxine, and vilazodone may reduce depression and anxiety symptoms and improve sleep during cannabis withdrawal. With the review, some medications appear to show promise for treating individual aspects of the cannabis use disorder. However, there was a lack of robust evidence to support any particular pharmacological treatment. While medication strategies may become a component for cannabis use disorder treatment one day, psychosocial intervention should remain first line given the limitations in the available evidence. In 2022, Lochte, Cooper, and Mooney did a review of evidence-based behavioral treatments. They found that behavioral interventions for substance use disorder continue to be the mainstay of treatment and have evidence for efficacy in reducing use and facilitating abstinence. This, again, is a reminder, there are currently no U.S. Food and Drug Administration approved pharmacological treatments for cannabis use disorder. There are various behavioral approaches which have been shown to have clinical utility in treating cannabis use disorder. They noted in a meta-analysis of 7 controlled clinical trials of adults with cannabis use disorder, psychosocial treatments were shown to double the chances of abstinence at 3 to 4 months. Follow-up 21% versus 10%. Treatment outcomes improved with longer durations of therapy and when interventions were combined. However, access, as we all know, access to evidence-based therapy is often limited. Insurance reimbursement may constrain options, and poor adherence to treatment is common. Even with evidence-based psychosocial treatment, abstinence rates remain modest, around 20%, and patients have difficulty in maintaining treatment gains after 9 months. Although they felt that clinicians need to continue to screen for cannabis use disorder and provide assistance in treatment. The first evidence-based behavioral treatment they discuss is motivational enhancement therapy. It is an empathetic approach focusing on individualized goals and psychoeducation. Motivational enhancement therapy is often less time and resource intensive compared to cognitive behavioral therapy. And some studies show that their efficacy in treating cannabis use disorder is similar. Motivational enhancement therapy may be ideal for patients who are ambivalent or who are just starting treatment. It can reduce cannabis use early in treatment. However, effects may not be sustained 1 month after treatment. The next behavioral treatment was contingency management. Contingency management uses incentives like vouchers or prizes to reinforce milestones on treatment, such as adherence to treatment or negative drug screens. Although contingency management has limited efficacy as a monotherapy in cannabis use disorder, it can promote longer periods of abstinence when combined with other treatment modalities. Cognitive behavioral therapy is a well-studied approach focusing on the thoughts, behaviors, and triggers that reinforce substance use. This approach encourages patients to utilize coping skills and problem-solving skills and to find healthy alternative behaviors to replace substance use. It should be considered as a first-line treatment for highly motivated patients or patients who have already started treatment, but it may have limited utility in more ambivalent patients. Current evidence best supports motivational enhancement therapy plus CBT-based interventions with the addition of contingency management, specifically when the treatment duration is more than 4 sessions and extends past 1 month. Other interventions or psychosocial treatments include counseling, family-based therapy, mindfulness, and relapse prevention. Likely have utility in treating cannabis use disorder, but they have relatively less supporting research. Although mutual support groups are popular and valuable resources for patients, they should ideally be utilized in addition to evidence-based psychosocial treatments. Okay, let's review the diagnostic criteria for cannabis withdrawal syndrome. First, cessation of cannabis use that has been heavy and prolonged. Usually this is daily or almost daily use over a period of at least a few months. Secondly, 3 or more of the following signs and symptoms develop within approximately 1 week of criterion A. This includes irritability, anger or aggression, nervousness or anxiety, sleep difficulty, decreased appetite or weight loss, restlessness, depressed mood, and at least one of the following physical symptoms causing significant discomfort, including abdominal pain, shakiness, tremors, sweating, fever, chills, or headache. The signs or symptoms from criterion B cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The symptoms are not due to another medical condition and are not better explained by another mental disorder. The onset of cannabis withdrawal symptoms typically occur within 24 to 48 hours after cessation of use. The early phase of withdrawal is usually characterized by insomnia, irritability, decreased appetite, shakiness, and less often sweating and chills. These early symptoms are most likely to peak at days 2 through 6. They improve as the THC levels reduce over 7 days of abstinence. Anger and aggression and depressed mood may occur as early as week 1 into cannabis withdrawal, but typically peak after 2 weeks of abstinence. Sleep disturbances may continue for several weeks longer. In regards to cannabis withdrawal syndrome, there is an article that was published in 2021 in the Journal of Addiction, and Jason Connor was the lead author. The authors noted that cannabis withdrawal referred to symptoms that occur after abrupt cessation or reduction in the use of cannabis products containing THC. Symptoms of withdrawal are seen most often in regular and heavy cannabis users. The most common symptoms are anxiety, irritability, anger, insomnia, depressed mood, and loss of appetite. Other symptoms include chills, headaches, sweating, and abdominal pain. The symptoms of cannabis withdrawal are noted to occur within 24 to 48 hours of cannabis cessation and peak in the severity at day 2 through 6 after cessation of cannabis use. They note that the duration and severity of cannabis withdrawal is correlated with the amount of cannabis use prior to cessation. They also noted that in heavy users, cannabis withdrawal symptoms can last up to 2 to 3 weeks. They do note that approximately 50% of regular cannabis users will develop cannabis dependence and withdrawal. The authors went on to note again, there are no FDA-approved medications to manage cannabis withdrawal. The authors found 20 studies looking at medication to manage cannabis withdrawal, 16 of which were standardized measures of cannabis withdrawal. So the authors focused on those 16 trials. There were 6 studies in which there was a benefit found for medication in managing cannabis withdrawal, and those studies looked at dronabinol, quetiapine, nabiximols, gabapentin, and THC. There were 10 studies in which there was no benefit found for medication in managing cannabis withdrawal, and those studies looked at lithium, dronabinol, lofexidine, bupropion, nabiximols, zolpidem, guanfacine, escitalopram, and nabilone. Some of the meds studied had both positive and negative studies, including dronabinol and nabiximols. The table shows what medications are often used in clinical practice to manage cannabis withdrawal. They noted that medications are often used in targeted fashion to relieve specific symptoms. This included suggestions for general withdrawal, anxiety and agitation, tremors, nausea and stomach pain, psychotic symptoms, and sleep disturbances. I personally would not use benzodiazepines, zolpidem, or promethazine when a patient is trying to stop cannabis use, as in my experience, patients with substance use disorders tend to not want to stop using benzodiazepines, zolpidem, and promethazines once they start, given the euphoria and sedation that these meds may cause. I would most likely focus on other meds on the list or use non-addictive medications such as hydroxyzine for anxiety and mirtazapine or trazodone for insomnia. The authors also noted that once the patient is able to stop using cannabis and has gone through their withdrawal, continue ongoing treatment of their cannabis use disorder is necessary to prevent relapse. Psychosocial interventions are first line, including cognitive behavioral therapy, motivational enhancement therapy, mutual support groups, and contingency management. Let's just quick touch on cannabinoid hyperemesis syndrome. In 2022, Rasman and a team discussed clinical information that I would just like to share comparing cannabinoid hyperemesis syndrome and cannabis withdrawal syndrome. In terms of clinical course, patients suffering from cannabinoid hyperemesis syndrome often describe three clear phases, which occur after a period of regular cannabis consumption, during which doses have been continuously increased to obtain desired effects. An initial phase of morning sickness and dyspepsia, lasting anywhere from several months to years, is usually the prodromal phase, during which patients generally tend to increase their consumption to benefit from its antiemetic effect. This is then often followed by a second phase, where patients experience recurrent episodes of hyperemesis with abdominal pain occurring in the hours after THC consumption. Each acute episode can last up from 24 to 48 hours, and it is during this phase that patients are most likely to take hot showers for symptomatic relief and tend to present to the emergency department. Following the second phase, a recovery phase with two possible outcomes arise. Either the patient can continue THC consumption, in which case the symptoms appear again, or they will completely abstain, in which case if said abstinence is maintained, the CHS symptoms do not reoccur. Cannabis withdrawal syndrome, on the other hand, tends to present in chronic users within 1 to 10 days after last THC intake, with a peak incidence between 2 and 6. No correlation has been established between symptoms, severity, and quantity of THC previously consumed, and initial presentation tends to vary, with clinical course not well defined. Symptoms, which include nausea and vomiting, as well as psychological and other somatic issues, generally worsen the further the patient is from their last consumption and can last up to 4 weeks. This likely corresponds to the time needed for the CB1 receptors to return to their original state in the central dopaminergic pathways. This important feature is key to long-term management of these patients who require ambulatory follow-up rather than simple symptomatic relief. The table summarizes the relevant clinical differences. Here is a quick little recap, noting number 3, there are no FDA-approved medications to manage cannabis withdrawal. Loki, Cooper, and Mooney, I had previously discussed them earlier, also developed a theoretical treatment algorithm for cannabis use disorder for clinicians considering pharmacological approaches in addition to behavioral interventions. I just thought I would quick include that. Thank you for your time this morning.
Gayle, great presentation. We've got time for questions, and we've got several questions in the chat now, so we can spend the next 15, 20 minutes covering some questions, cases, whatever you have. I'll just kind of start with what we have in the chat so far, and feel free to drop in questions, or if you want to speak, you can click the raise your hand button and so see, Clint started asking which screen is best or evidence-based. Gayle, do you have any thoughts on preference for screening for cannabis?
Um, I like the cast. That one seems to be my favorite when I've used it. There's also the Caught It R that I really enjoyed as well. I think that's a good one. It just kind of depends on what you prefer. I can include some examples of those or additional websites or copies of those to be used.
Yeah, that'd be great. Maybe we can, in that follow-up email, I can send out some links to those screening tools. So we also had a question from Clint, asking if a patient is using it for pain, using cannabis for pain, what might you offer as a substitute? I saw John did respond to that one in the chat. So John said that he's advocated for management of pain with buprenorphine instead of THC as safer and more effective management option. Then he added that buprenorphine in his assessment of literature is not to become the first line of opioid for chronic pain management due to efficacy, safety, and sustainability advantages. Anything to add there, John or Gayle, about buprenorphine in relation to pain?
Oh, there's a follow-up question about buprenorphine studied for cannabis withdrawal, and I'm not aware of that. Somebody might have better information about that.
Thank you. Let's see, we'll go along to the next question here from Michael. How long will a urine drug screen remain positive after cannabis use? How does this affect the use of the urine drug screen to assess compliance with treatment and cessation of cannabis use?
With cannabis being lipophilic, sometimes I will see those drug screens be positive for 1 to 3 months after use. I would say on average, probably 1 month.
And then, so the second part of the question, does that affect how you assess compliance with treatment and cessation of cannabis use?
Usually when I meet patients, I really try to build a good rapport with them. You hope that they're being honest with you because your goal is basically the same as theirs. A lot of the people that I do see with the cannabis use disorder are also on probation, so they are getting a lot of screening done through the legal system. And I don't really like to rely 100% on urine drug screens. I think that I use them, but I also feel like I overuse them. And maybe it's not as necessary just with seeing patients on a regular basis and kind of understanding and knowing them. I also live in a small town, and so I have access to who's in jail. I see the patients at the jail. So I kind of have a little bit of a underground information too about who is having struggles and troubles, which kind of helps me in that department.
Let's see, next one's from John. He asked, how do you manage patients with polysubstance misuse under treatment with successful abstinence and stimulants, ETOH or opioids, but that continue to use THC?
Usually with polysubstance use, I kind of go after the substance that causes them the most dysfunction. For example, I do have a fellow that has polysubstance use. He's 65 years old. When he used methamphetamine, he would become very dysfunctional and he would have a lot of issues with his family. He's been able to be off of that, but alcohol is kind of an issue for him. And he does take 2 hits of marijuana every night to help with his restless legs. He's been abstinent from the methamphetamine for 3 years, but we've been trying to chip away a little bit at this alcoholism. And with him and his age, he's pretty stuck in his ways quite a bit. And so it just takes a lot of time. I wish that it was quick, like strep throat, and I could give him an antibiotic, but it's just kind of this little bit back and forth. And they seem to kind of test the waters a little bit where hey, he will abstain for a week because he wants to come back and tell me next week I did a great job. And then the next week he'll just binge. Um, and we have tried different medications with him. So I guess to answer the question is I start with the one that causes him the most dysfunction, and then I kind of go from there. It also helps me treat the symptoms of their withdrawal too, if I can just focus on one substance.
Any thoughts from the rest of the ECHO team on any of these questions or polysubstance use?
Yep, I just wanted to add on that. I completely agree. You know, tackling one substance at a time, and I personally always kind of leave it up to the patient. I mean, they'll kind of tell you what, you know, as Gayle mentioned, what kind of is their primary drug of choice that they wish to stop. And so when there's multiple substances like cannabis, I will be completely straightforward and I'll say, you know, if you use it consistently, continue doing exactly what you're doing to kind of establish that rapport. And so I kind of put that on the back burner. I basically give them permission to do whatever they're doing with the other substances, and then we just kind of focus on that. And as the rapport established, more of the kind of honesty and how much they're actually using really comes out, and they can get that trust with you. So completely agree with what Gayle said, but just want to add a couple more bits.
Yeah, and we've got about 10 minutes, so keep the questions coming if you have any. We've got another one here from Clint asking, is screening for other psychiatric illnesses recommended during assessment or treatment period, for example, anxiety, depression, ADHD, anything like that?
I think when I kind of talk to people about their substances, I usually include evaluation of other disorders, mood disorders, anxiety disorders, but I also feel like I get a lot of information from the patient when I ask them specifically why they're using the substance. You know, especially like if you talk to people about cannabis, well, I use it for pain or it helps my anxiety. And then I kind of cater my treatment as maybe we need to kind of give them some medications like an SSRI or something to help with that anxiety and see if that would help them kind of reduce their use.
I see a couple more come in. Do you discuss any of the oral effects of substance use and or the medications prescribed to treat substance use disorders?
I do. Sometimes people kind of roll their eyes at me because they feel like they're getting such a benefit from them. It takes a lot to convince someone that their problem is the marijuana or excuse me, the cannabis. But it's pretty rewarding when you can get them to stop. And I think about a gal that had hyperemesis issues, and she felt like she kept on smoking more and more because she felt like it helped her symptoms, but then it would just kind of rebound and she would be sick. She missed so much school. And kind of when we started to get her to kind of back off on that, and then she was able to see that. Um, um, and so I do include that with my discussions with the patients.
Any thoughts on the last two questions from me? Anyone else on the ECHO team? Otherwise, I can go to next.
I just wanted to add one more. Gayle, completely agree with everything you're saying. As you guys will notice in my lecture at the next session, I'm a huge advocate for absolutely screening for ADHD, especially with polysubstance use. And it they don't necessarily have to have gone to meth. A lot of times, maybe they haven't been exposed to it yet if there's an underlying ADHD. If they do have ADHD and they do use meth, that will eventually become their substance of choice. But if they haven't used it, you'll kind of notice this no clear preference of drug of choice, and they're just kind of using everything. And they're like, well, I could stop if I want. I don't really like any of them. When you kind of get those inconsistent answers, absolutely screen for ADHD, especially even in ones where they have a major criminal history and a lot of it is substance related. During assessment, that's one of the first things that I do is for ADHD, because if you want to treat the substance use, you really have to treat the ADHD first.
And Kevin had a question. I apologize, Kevin. I saw your question and I must have scrolled by it. I was really good at this, so I forgot to do this. Kevin asks, can you explain how the type of hemp products that are available legally in Nebraska dispensaries differ from cannabis, and what different effects they may have compared to cannabis? Are they
So I can answer this. I actually gotten a big legal discussion about this with attorneys a couple days ago. So I have pretty good knowledge on it. So hemp is within the category of cannabis. I mean, it all comes from the cannabis plant, but what considers hemp versus what considers the marijuana that we think of is the THC component. And to be considered hemp in Nebraska and really all states, for the agricultural purposes, it has to have a THC of less than the 0.03 or 0.03. And so from hemp side, essentially you can't get high from it. And marijuana side, again, all comes from the cannabis plant, then you get all the euphoric and substance use effects from marijuana. Hopefully that makes sense.
anything else on the legal cannabis plants?
I did, when I was preparing for this presentation, there was discussion about a fella who was in a state where he could be prescribed medical marijuana. And he was traveling through a state that did not allow for the THC products. And he was arrested because he had a scale and he had the medication. And he was told by his provider that he needed to measure out the doses. And so he was following all the instructions of his provider. But when he came into that new state, they didn't recognize that. And he ended up doing prison time. And then there's some big advocacy groups that stepped in to try to help him out. But it does get kind of muddy, I would say.
Next question, a kind of follow-up question from Catherine. Do you ever discuss effects on the teeth or gums? I think perhaps in relation to cannabis use, or maybe she's from Suboxone as well. Any discussion or of
It surprises me how many people don't brush their teeth. I usually include good oral health or discuss that because I feel like if they have good oral health, that also helps with their brain health as well. But I usually don't really go into effects. I haven't, but that's a really great thought.
Hey, Catherine, I don't know if the question that you're asking is related to the more of the Suboxone side of things, but there has been a lot of stuff that's been out there that Suboxone could be really hard on people's teeth over a period of time. And so we do really try to highly educate patients. I know this isn't like Suboxone specific, but making sure that they're like brushing their teeth afterwards or switching them to the injectables if they are having dental issues from that medication. So you can expand more
Great,
on.
fantastic. This is Catherine. I'm not on camera because I am going to go work out soon. But yes, and then we had recently had an article in the Journal of the American Dental Association that highlighted that. So that's why I was asking. We also, as dentist, I'm a dentist, see that there's just a lot of dry mouth with the cannabis use. And that leads to dental caries just in and of itself, just like any other medications that you give folks. So I was wondering if people were discussing, especially with the Suboxone, hygiene or swishing with water or anything like that after the use.
Yeah, thank you for that.
Any other questions? We've got a couple of minutes. While you're thinking about that, I did drop in a link to the evaluation survey in the chat. You can go to that link, do a quick survey, and then your certificate will pop up immediately afterwards. I'll also be sending out an email later this morning with that link. Do check your junk mail. I had a couple of people tell me that my emails have been going, which is unfortunate. So if you don't see it, check that and maybe add me to your safe senders list. Other than that, we've got a couple minutes, we can call it here unless we have any final questions come in or any final thoughts from the team. Not hearing or seeing anything, so thanks for joining us and great job, of course, Gayle. We'll see you back in a couple of weeks. Stephanie will be doing a presentation on treatment for methamphetamine use. So, thanks.